I'm delighted to say that we have some very distinguished and original thinkers joining our panel. You've already met two of them, Jessamy Baird and Jonathan Van Tam. So please, let's meet the others. Can you please welcome Sarah Woolnough? She was referenced earlier. Now, Sarah is the CEO of Asthma and Lung UK. So please, Sarah, join us on the stage. Can I also add as well that Sarah is co-chair of the NHS England Respiratory Board. Next up, could you please welcome Baroness Nicola Blackwood. Please come and join us. Let me tell you a little bit about Nicola. She is an acknowledged leader in science and entrepreneurship. She's also a member of the House of Lords and chair of Genomics England. And I believe that you are also one of the youngest committee chairs in British history and the only woman to have chaired the Commons Science and Tech Committee. So thank you for breaking through some glass ceilings. I think we deserve to be recognised for that. Okay, another trailblazer. This is our final panellist, Paul Blakely. Now, Paul is an experienced health and life science policy expert. I'm glad you moved because it's no point you sitting there. Please do come and join us. And let me tell you about Paul. He spent 10 years working in the UK government, focusing on clinical research, market access, and the adoption of health innovation. He also had a short secondment in the NHS before taking up his current role as lead for life sciences and health policy at the Tony Blair Institute for Global Change. And I believe that your focus there is the future of health and care, also the link between health and wealth, and opportunities for the UK and global life sciences sector. And of course, they don't need much of an introduction, do they? Jessamy and Jonathan Van Tam, please come and join us on the stage. But before I put the question to the panel, my question to you, the audience, is, are you guys ready? Yes. Excellent, okay, because I'm going to put a question to you. You know what to do. Use the QR scan. If we can bring it up again, please. Thank you very much, so that you can actually ask the question or answer the question, which I'm going to put to you now for the Sanofi poll. Do you think members of the public see the value in life sciences? Do you think members of the public see the value in life sciences? So, let's get your response. All processing. In fact, whilst those numbers are processing, I'm going to move over here. Sorry if I'm actually getting in the camera line, by the way. I'm not doing that deliberately. Here I am. So do you think members of the public see the value in life sciences? We don't seem to be getting much of a response to that at the moment. We are getting a response. OK, we'd like to see it animated. I'm sure it takes a little bit of time. Let's not try to preempt those figures. They will come up. But look, somebody has to draw the short straw to kick off the conversation. In fact, before we start with you, Sarah, the data has come up, OK? So 42% of you are very optimistic. You think that members of the public see the value in life sciences. The rest of you, perhaps not quite so sure. So I guess the question has to be, Sarah, that implies that perhaps a fair chunk of the public don't really understand or even care about life sciences. We should, but the reality is that most of us don't. So, I mean, why is that? What is the perception of the man or woman on the street, and why do they feel so negative?
Well, I think I'd challenge the results, actually, if I may.
Go ahead.
And I suppose partly I've spent the vast majority of my career in medical research charities. So I've had the privilege of spending a lot of time talking to patients who are often accessing research. And of course, my experience is therefore that they really do see the benefits of medical.
I could be controversial and say that you're dealing with a very specific base.
Quite. But I suppose my answer is, you know, you have to take people on a journey and you have to sort of set out the benefits. If they can, you know, if it's disease specific, if they're affected by a condition, they often will absolutely see the hope is medical research. And, you know, we have a pretty unique medical research charity sector, funding huge amounts of research in the country, pretty unique by international standards. So there is a good understanding, at least amongst a cohort, a section of the public, that if they're giving to a cause or they're supporting research in some way, that's hope for the future. And it may be treatment for them, it may be treatment for others. I think I'd make one other point, which is we can never be complacent about this. And actually, if you want to generate support for the life sciences or medical research, you have to keep at it, like any kind of campaign or endeavour to raise awareness and generate support for something. So you have to make it real and tangible. I mean, and it partly depends how you phrase it. People aren't going to support for its own sake if they can see how it's impacting them.
All right, so let me just jump in here because I'm conscious that we've got quite a lot to actually cram in the time available. But generally, in spite of that figure, you're quite optimistic, OK, because people do feel that it is relevant to them. Even if they can't describe it as life sciences, they get the point of it. So is that view shared by other members of the panellists? No, you don't. You disagree, Jonathan?
Yeah, so I think clearly the public wanted a vaccine or vaccines for COVID-19 as much as anyone else. And I think they got it, that scientists gave them that, and then the industry made it at large scale for them. But I think we're having this conversation in the adult space, and I actually think I want to take that conversation back into the childhood space and say, I don't see enough kids having that completely life-changing eureka kind of breakthrough, penny drops experience about what science actually has and has done in the past and can do in the future. And so I don't think we are educating a generation of the next generation to be, deeply engaged with what the life science industry can do in the future. So I think we're missing a trick early on in engaging people.
OK, so education, once you get it right, catch them young, then basically you'll get that understanding.
I would agree with that. I'd say two things. I think it depends where your baseline is. So during the pandemic, there was huge awareness of the industry and the value the industry provided. Ipsos did some really interesting polling in 2021 on this, which showed there was a big boost in public understanding of life sciences and the value that it brings. Where there was still uncertainty was public didn't really understand how life sciences operates or how it actually functions beyond the delivery of individual products.
But there's still an information deficit there. That's
exactly. There's an information deficit. There's also how do you help the public understand that? And to your point earlier, how do you help the public understand the value of life sciences beyond the product? That's what we need people to get. It's hugely important for our economy. It's hugely important for growth, and it's hugely important for high-value jobs. It's not just the vaccine or the products it produces.
Yeah.
Okay.
I mean, I would say it is fairly normal for us as people to just want the public sector to work without us caring about it unless it directly affects us. And then the minute it directly affects us, we really care about it. And so at Genomics England, we have an extraordinary participant group who are involved because they're clinically affected either by cancer or by rare diseases, and they come in themselves for diagnostic purposes. There is a 94% consent rate for participation in research. At the same time, the NIHR run a dementia research program looking for volunteers. 74,445 have joined. The public are committed to health research. They understand the value of it, but obviously the rate of commitment is much higher if you're personally affected. That is normal human behavior. And I do agree completely with JVT, saying we need more scientists, we need better science education. But I think it's unreasonable to expect every member of the general public to understand MHRA regulations.
OK, so basically what we expect of the public, I mean, I shouldn't say we, because I don't work in the life sciences sector, but what some people perhaps expect is a bit unrealistic, Jessamy.
Well, I think there's just a tension there. Because I think there's a big difference between being involved in research, and I think you're right. On the COVID app, there were, I think it was 200,000, or there was very high numbers that were carried forward in terms of consent. And having worked in the NHS on an NHS board with responsibility for research, getting consent to take part in research and getting any level of attention when you've got struggles with safety and struggles with staff and struggles with finances is really difficult. So I think the question actually is how can we keep that focus on research in a way that, as you've said, it improves the ability of people to take part in research, it improves the health of the population, and actually, ultimately, it does have economic benefits as well. So I suppose one of the what-if questions would be, can we bring that back? And I know the Future Health programme is trying to get the public back engaged with that kind of major research consent. So I think there's more to be done bringing that kind of mindset back.
So strongly agree with that. And I mean, I think one of the things is to having much more opportunity for direct communication, maybe through consent for research and engagement through research on the NHS app. There's like 30 million patients on there, and that will grow the more services that go on there. And that's actually a really exciting programme on the NHS app. And I think people would be engaged, but then also reporting back to participants of the outcomes of those trials and much more direct engagement. And I think there's a lot of agreement about this. We just need to speed up progress towards that.
Yeah, and that's a fair point because, again, as you've all raised, we tend to be engaged with life sciences if there's something which is happening directly to us. If you've got somebody who's actually got cancer in your family or Alzheimer's or whatever, but if you don't have any of that, then you're quite remote. But I mean, look, you can't have this conversation without looking at COVID-19. I don't want to go too far down that, but look, the key thing which came out, apart from the vaccine, the lives it saved, the differences it made, etc., were the conspiracy theories, okay? Do you think that perhaps those conspiracy theories, the people who've successfully propagated them, have perhaps made it more difficult for life sciences to connect with the public? Because in some respects, and I've actually heard this amongst some of my own circle, that they're not just sceptical in terms of the COVID-19 vaccine. For some people, it's all vaccines.
I think people have to make their own decisions. Vaccines are about population health and always have been, and people have the right to challenge and to question, and we've always supported that. I think in terms of the public debate and the life science sector, I think we work with often patient organisations, because I think there's a bigger topic which is less about that side and more about how do you reach diverse populations. And when you look at vaccination rates, for example, across parts of London, you would be amazed at the difference between one section of the geography and the next door borough. And I think also you see that in health outcomes in preventable diseases across the country. You get differences in life expectancy of 12 years within one integrated care geography. So I think it's more about how do you reach populations who aren't necessarily getting the access to health services they need, or finding it more difficult to access the services. And as a life science sector, what we're trying to do is make sure our clinical trials are more accessible and more diverse and more reflective of the population we serve. So I think there's probably less that. People obviously can question things, but I think it's much more about how do you reach populations who aren't.
It's the bread and butter, because I know that this is something which you're very passionate about as well, that the connection between health, economics, lifespan.
Yeah, exactly. I mean, I think you only have to look at what's happening with measles, right, in London. There is an issue around this, but I think we need to avoid overblowing it. Just to Nicola's point, like the number of people who are willing to consent to participate in research when they're offered the opportunity is very reassuring. Like, people genuinely, when this matters to them, they understand the benefit of it. Just back to your previous point slightly, the reason that I'm so supportive of direct communication to patients is that I think we're a bit overly fixated in the system on trying to push everything into the NHS. What we don't do enough of is generating patient pull. And what I would like to see through things like the NHS app, and why we're arguing for a personal health account, is to give patients more opportunity to participate in this. So more opportunity to participate in trials, more opportunity to see the guidance on the latest treatments that might be relevant to them. At the moment, we're expecting clinicians to pass that information on. We're not giving patients the opportunity to engage directly enough.
So more patient involvement. Can I go to you, Jonathan, to get your take on this, and also you, Sarah, and then we will get another poll question which I'll put to the audience.
Yeah. So I think you're overblowing the kind of anti-vax sentiment in this country. Actually, this is one of the most vaccine-accepting countries on the planet. And if you kind of drill down into why people are not vaccinated, so much of it is about apathy or access, and you see that in the kind of uptake rates by deprivation. It's not easy to turn up to a vaccination appointment or ring for one if you've got 3 0-hour contracts. It's just not easy.
So that's the economics, effectively.
Or if you've got 3 children under 3.
Yes,
exactly. Your lived experience is such that it's just not top of your priority list, like it might be top of mine. So, there's all of that going on, and I think there's much more kind of apathy, and hesitancy than there is actually anti-vax
So
sentiment.
cracking through the
So-
apathy. Sarah, good point there, because yes, once people feel it, they'll take it. We are a vaccine-accepting nation, but at the same time, the challenge, okay, bearing the what if, is how do you actually reach out to those communities who, for whatever reason, they're not actually embracing the medicines and also earning their trust as well. If you could be brief so that we can actually put another question to the poll.
Completely agree with that point. And actually in COVID, there were fantastic examples of work with communities to get COVID vaccine uptake. And we've been doing some work with Brent Mosque, who were wonderful at this in their local community, to sort of build on the back of that. I think this point about vaccine apathy is something we need to take reasonably seriously. So as a respiratory charity, we work on flu vaccination, pneumonia, RSV, which will come on. And as something that helps prevent winter pressures, you know, back to the conversation about sustainability of the NHS, we do want to continue to make the case, even perhaps moments that aren't considered crisis, for a good vaccination strategy that reaches out to people.
OK, let's go on to the second question for our poll. Do you think health systems, the government, industry and others engage in effective partnerships to drive improvements in life sciences? So if we can animate the question, there you have it. Do you think health systems, the government, industry and others engage in effective partnership to drive improvements in life sciences? So you know what you have to do, the QR code, I'm sure you've scanned it, so if we can have your response. You've got three possibilities there, definitely, somewhat or not at all. And whilst we're waiting for those responses to come through, they should be through fairly soon, but let's continue with the conversation, because I guess the point that I want to look at now is really this whole idea about broadening existing alliances. There are the numbers, so definitely 10.81%, let's round it up and say 11%. I can't see the number there for somewhat. I know that definitely has gone up a bit.
78, I think.
Lovely, thank you very much. OK, I don't really have eye problems. And just under 10% for not at all. But look, whenever you're looking at life sciences, and I'd like to get your response to this as well, is, you know, you talk about broadening existing alliances. We saw, for example, during the COVID fight, we actually saw VCs coming into this, okay, because they had so much to bring in terms of the vaccine package. But we do know as well that the life sciences ecosystem is extremely complex. So where are the opportunities to actually broaden existing alliances, given that what we're trying to do is to enable patients and indeed other stakeholders to navigate this healthcare landscape just that little bit more easily? So, Jessamy, if I can put that question to you and then get the response of the rest of the panel. You're obviously waiting for it because you're nodding away vigorously.
I'm with the majority, with the somewhat. So I suppose you could call it patchy. I mean, so we call it the ecosystem, but really I think there is a tendency to sort of pick at specific issues and look at them separately. And I think what the COVID experience showed us, it was actually when you bring the whole thing together, that's when you can have an impact. And certainly as a life science sector and working in that space, I think it feels quite inconsistent, and sometimes you get really great traction. So I think things, you're talking about venture capital and IPOs and all of that, there's clearly work going on to change the way the financing and of early research. There's very powerful early research in this country. I think clinical trials we've already raised, there is a challenge there, and it's a really visible challenge in life science sector, and remaining really at the top of the global attractiveness, and let's face it, that is a challenge for us now. I think our regulatory system is, you know, globally and internationally recognised, and the way they actually do partner with us. So, you know, NICE, for example, as an organisation, has always collaborated, been completely transparent, spoken to us. Whatever you think of the result for your special medicine that you treasured, they actually have got very good, strong global international respect. And so do our regulators, the MHRA, in terms of bringing medicines rapidly through. So I think there's lots of pieces. I think really when we're looking at, we need to look at it in the round, and sometimes in terms of actually ensuring people, patients get those vaccines or medicines, that's where sometimes we can feel it can feel more them and us, and we're trying to really make sure we focus on areas of common
actually break
benefit.
down the divides.
Yeah, and stop seeing it as a piecemeal, see it as a whole.
Yeah, because I know that was something which you referenced as well in your conversation with Jessamy, Jonathan, about breaking down these divisions, them and us.
So I think there need to be a series of conversations, first of all. You know, there needs to be a conversation with the population about what it wants back from its National Health Service now and in the future, what its lay vision is of things that should be treated, could be treated. That needs to be brought into some alignment with a professional view from government over what the big public health challenges of now and of the future are. Then the life sciences sector need to be brought in. And where you get alignment of all three, you will get relentless focus and progress. But everyone has to accept that there may be some areas around the edges where it's a priority for one constituency, but not realistic for another, where it's a priority for life sciences because there's a potentially very profitable medicine at the end of this, but actually it's not a public health priority, and it's where the alignment and the overlap come, where patients say, yeah, this is important for us, for the future of my family, for the future, for my kids' next generation, where government says, yes, this is a big problem that we've got to solve, and where the industry say, yeah, we've got some good stuff here. Those are the sweet spots, and you can't expect, I'm not surprised at that result at all, partial. I thought that's an inevitable answer, because actually you can only expect the low-hanging fruits at first to come forwards.
Okay. Let me jump in here because, look, whenever we're talking about alliances, broadening them, whatever, the M&A which you talked about there, Jessamy, is you can't get away from this idea of innovation. So much innovation, in fact, is taking place in the sector. And, what does that tell us about what patients want from their future care? And if I can throw it open to you, Paul, and to you, Nicola, and also to you, Sarah. And how do we get demand signalling from patients so that they can actually signpost what they want to see from those healthcare innovations? Because there's always that danger that innovation becomes a bit pointy-headed to the exclusion of the people who are meant to benefit from it the most.
Yeah, well, if I give you an example, Asthma and Lung UK, I mean, the very short answer is talk to people, talk to them early. So we get a huge amount of patient-public insight. We speak to thousands and thousands of people every month, most living with a chronic lung condition. We're a huge repository of insights, and we have an innovator community working really hard, particularly perhaps around self-management of chronic lung disease. We're trying to bring the two together earlier, because what we often find, if you just take apps as an example, how to manage your asthma or your COPD, how to predict an asthma attack, often I don't feel patients and the public are involved early enough. We think this is what people want, but yet the usage figures suggest otherwise. So I think it's really trying to talk to patients and the public, talk to them early, involve them. But what do patients and the public want? Well, they want good treatment and they want it consistently. And I mean, I would really emphasise that point at the moment about patchiness. In respiratory care, the inequalities are so stark. And yet the trials activity does absolutely not correlate with the burden of disease. So if you map poor lung outcomes and then you map clinical trial or other research activity, the two are quite far apart. So I feel very passionately we have to do better to get out and reach the communities with opportunities to take part in research where they are.
Okay, can I get the response to that from you, Paul, and also Nicola, and then we will get the final poll questions put to our audience.
Yeah, two quick things. One, I think partnerships work where everyone is pointing in the same direction, right? So it's why the mission concept under Life Sciences Vision really works. And working with sort of patient groups and frontline staff to understand what the outcome of those missions should be is critical.
I just want to return to the point that was made by Jessamy at the beginning about the fact that this is a pipeline. When I started off, I understood exactly what you presented at the beginning of the show, that we had this amazing reputation in the UK for having a brilliant pipeline from science all the way to adoption, but that it had points of friction through that pipeline. Now, since then, obviously, we've had a pandemic and various different things, and so there's even more friction in that pipeline. We've got the clinical trials fall off, problems in the NHS, pressures with MHRA post-Brexit and so on. And the life sciences vision and various different actions from the government are trying to address all those bits of friction. The O'Shaughnessy report is trying to address, the 27 different recommendations to improve clinical research, and some of that is already being acted on by the government, but that does need to go further, and it needs to go fast, because we're not going to be competitive if it doesn't. The MHRA has been given money to improve capacity and to speed up. Nice reform is going on. You've got Sam Roberts, a fantastic CEO, but she does need support, and she needs support from unions as well, because it is a unionised organisation. But the bit that nobody talks about very much is adoption. It's no good having a great pipeline all the way up until you have products, and then it's not getting to patients, because that's the whole point of why we're doing it. And it's great for us to be a testbed for the world, but we want those products to be getting to NHS patients as quickly as possible.
So I just want a nuanced intervention with efficient, unified delivery across the system, because that's also so important.
If
But I would
may,
consider that was innovation as well, just making sure people were on the right pathway.
It is innovation of a different sort.
Yeah, it
yes,
If I may, I
absolutely.
think just to say that
Very, very briefly, so that we can get
very
the third poll
briefly, but it
question.
is absolutely the position we've been discussing medicines equity with NHS England, and the position of the sector represented by ABPI as a trade body is that actually you're looking at pathways of care. These missions are about pathways of disease management, identification of people at risk. It is not about individual technologies. So to your point, completely aligned. It's about a very complex system, and patients finding their way through it. So
Okay, could we just hold fire for one moment, because there is plenty of ground to cover, but let's go to the third and final poll question to our audience. To what extent do you think that the pandemic taught us lessons which we can apply to the improvement of the UK life sciences sector? So that's the third question coming up on the screen. There you go. To what extent do you think the pandemic has taught us lessons which we can apply to the improvement of the UK life sciences sector? You've got three options here: definitely, somewhat, not at all. Do you know that's disarmingly similar to before? There's déjà vu going on around here. OK, so whilst we wait for the response to come through, I know that, Sarah, there was something which you wanted to add to the previous remark from Jessamy.
Well, it's the point about, I suppose, adoption and spread. And I think this is where it comes back to the sustainability of the NHS. So the story we hear time and time again, the main theme on our patient helpline is, I can't get into my GP. I struggle to get GP access. I'm not getting access to my basic care. I haven't had my inhaler checked. I haven't had my COPD annual review. And it's that basic care that's the foundation. I haven't got a diagnosis, I haven't got a formal diagnosis because I haven't had the diagnostic test. So this issue about the NHS being under such stress and strain is so intimately related to adoption of innovation. The story is often, the system is gummed up at every point in the pathway. And until we address that, actually, we're not going to fundamentally crack the problem we face.
Okay, Paul, I know that you want to respond to that. Can you also incorporate into it your views on those results? Because in terms of the question, we've got, again, it's my eyesight, I think it's over 70% saying definitely, just over 20%, just shy of 21%, in fact, saying somewhat, and 0, not at all.
Yeah, I think that's right. I mean, I think my note of caution would be, to Jonathan's point previously, the pandemic taught us some great lessons. It blew apart this idea that some things were impossible. So if you look at how quickly remote consultation spread throughout the NHS, before then everyone was saying it'd take decades. It was done in weeks. The slight issue is, to Jonathan's point, it required people working flat out for a very clear national emergency. You cannot expect people to work like that day to day. So where Lord O'Shaughnessy, as I think is a bang on the right lines for commercial clinical trials, is create the incentives in the system for people to do the things you need them to do. Yes. So for commercial clinical trials delivery, allow care groups to retain a portion of the revenue they generate from commercial clinical trials. You need to stop thinking that NHS staff are sort of martyrs to the cause, and they will forever do more and more for less and less. You need to create the incentives in the system for them to do what you need them to do.
OK, then, look, what I'm going to do is I'm going to rest my tonsils for one moment, because I'm going to throw this out to the audience to see if they have any questions. We've got a couple of questions here. Before I go to those, is there anybody who's an extrovert who's quite happy to take a microphone? We've got 2 extroverts over there. So when you introduce yourself, before your question, can you introduce yourself and the organisation you represent?
Hi, everyone. So my name is Pedro, and I'm one of the analysts for the Office for Life Sciences, responsible for the life sciences competitiveness indicators that were mentioned earlier. And I have a bit of a comment and a question to the panel. So the comment pertains to one of the indicators that was flagged recently, and I think I can paint a slightly more positive picture. So the FDI figures decreased 47% year on year, but they're up 193% since 2012. So I think there is some hope there, and there are some positive indicators. And I think my question to the panel has to do with what they think are the priorities in the ecosystem and where we need to focus attention. So what are the bits that they think require more attention from us and more focus? And do those align where the incentives for all the different parts are aligned? So I think it's a slightly tricky question, but I welcome their views on this.
It is a tricky question, so who's brave enough to take it?
I can take that one.
And then you can have a go, Paul.
I think it's a very classic case of statistics, damn statistics or whatever the quote is, of where it depends what you're looking at and your framework. I think some of the areas that I think need attention and focus, we've discussed some, which is about adoption and really, I think, also about prevention. So I think there needs to be more conversation about longer-term prevention, not always looking at short-term capacity constraints, but how can we actually stop that burden of disease constantly increasing if you could take preventative measures of any sort, whether it's therapeutic or otherwise. I think some of the areas where there could be incentives in the system around clinical research, there is value to the NHS and to patients themselves, and there is actually financial value to the NHS of getting involved. So how can we support capacity-constrained system in kind of really galvanising that? And I think O'Shaughnessy had some great ideas on that. The other one is data. So there is amazing data.
Lots of it as well.
Lots of
from
it.
different sources.
Are we really capitalising on that as a country? Because I think you could completely revolutionise our ability to do trials if we could make somehow those interfaces work. And that's a bit more of a longer term investment, but if we could really get people aligned around it, and having been a CSIRO in the NHS, which is a Senior Information Responsible Officer, I know that quite often you just look after your own data here and you don't share it. And that's a kind of national debate. What if we all were happy to own our own data, to your point, personal health record, and share it? We could then do amazing things.
If it's any consolation, silo thinking is also endemic in financial services and insurance. I hear them talking about it often enough. But Paul and then Nicola.
Yeah, I'd say three things, some of which we touched on. One, regulation, which Jonathan mentioned. So I think we need a much clearer sense of what the strategic play is for the MHRA and how is it going to remain an internationally competitive regulator. Adoption, we've covered, and I think incentives are key there. The third one I'd add, which we sort of haven't mentioned, is the commercial environment. Now, the NHS doesn't pay a lot for medicines, and it shouldn't. But we do have to recognise that if we continue to operate a sort of focus on in-year cost control above all else, the competition globally for life science investment is increasing. That's what the UK needs to remember. We work across 39 countries in TBI. Every single one of them is talking to us about life sciences investment. So we're not just going to be competing with the traditional competitors anymore. There are whole loads of new markets emerging that we'll need to compete with.
Okay, and Nicola.
So I agree with both of those. But the other thing is pace. So decision making in the NHS and also in government is painfully slow. And there are lots of processes and reasons and justifications and safety excuses, but actually we need to pick up the pace if we want to be competitive. And so that would be the first one. The second is people. We obviously, in a competitive environment, need to have mobile people who can move back and forth, and so that's an immigration question. But also we need to pay people competitively compared to international competitors. And there's a whole bunch of questions around: Are we really going to think about that carefully? And the last thing is we need to have the right places to do business. So we need to have enough labs. We need to have the right real estate, and we need to invest in that properly and think about how we're going to do that. And it shouldn't all just be in the Golden Triangle.
Okay, fair enough. I know that there was a gentleman who actually wanted to ask a question. Just hold fire for one moment, because we've actually got some questions which have come through on the tablet. How do we ensure clinicians and health professionals have time for research, as the Academy of Medical Sciences, other organisations have called for? Jonathan Van Tam, would you like to tackle that one, or shall I pass it amongst your fellow panellists?
Well, as somebody who's actually been a clinical academic for most of their career, even a clinical academic when I was seconded to DHSC for a brief holiday. Being a clinical academic, so somebody who has clinical duties, who also has an employer demand to conduct high quality research and publish it and to teach people, it's a really, really difficult career pathway to follow, and it's getting more and more difficult. So, you know, if you take a professor of geography, okay, and look at their research output, they've basically got 5 days a week plus the weekend to do that. If you take a professor of surgery, who's on a typical joint academic NHS contract, they've got 2.5 days a week to deliver the same amount of research plus weekends, except for the fact that they are cutting for 2.5 days a week or doing, you know, other clinical stuff, and they might be on call 1 weekend in 4 or 1 weekend in 6 on top, and have to be available to go back into the hospital for emergency surgery. So, you know, their lives are very difficult in comparison in terms of research output.
Okay, then can I move it along to the rest of the panel? Would anyone else like to add to that at all?
Well, I could say I do think it is extremely difficult if you are in a situation where you have safety risk in your organisation due to insufficient staffing on different levels and different wards. You have issues with bed capacity, and anybody who's been out there lately, it is so difficult in some of those situations in organisations. They're on black alert every weekend. As you said, the whole team on call. There's no flow through the hospital. I do think that's a very difficult environment then to say, oh, let me think about spending that time to get somebody onto a trial. I think that, to the point, I think O'Shaughnessy has absolutely recognised that and has talked about the trial networks. There is the piece about how can you get increased capacity into the health system. But I think it has to be aligned to the workforce strategy. Until we get the workforce strategy sorted, I think clinical research is going to be impacted, and we have to just try and find a way to support staff to get involved, because I think they also really relish the opportunity when
It's
they do.
the what if.
Yes.
Paul.
The only thing I'd add is maybe also think about new routes into clinical research for people to take the burden off clinicians. So if you look at something like Relieve IBSD, which is a great example of a UK clinical trial that used virtual trial delivery, and I think they increased their participant recruitment rates by about 67%. So there are ways of doing it that don't put the burden on the clinician every time.
Okay, we've got a few more moments left. If we can actually take a microphone to this gentleman here in the blue shirt. He's been very, very patient, so thank you so much for that. If you could introduce yourself and the organisation you represent, please.
Sure, thanks. Owen Jackson, I'm Director of Policy at Cancer Research UK. I'm glad that I assume it was Simon, asked that question about the AMS report, because I fully agree. My question, though, is about funding of research. And one of the things we learned through the pandemic on that last question was the critical reliance the UK places on research charities like Cancer Research UK. And we're a very unusual country. So we're below mid-table when you look at OECD about how much public sector money we invest in research and development, whether you look on per capita basis or GDP basis, we're bottom half of the table. If you look at the US spends 5 times more on per capita on cancer research than the UK. Public sector money, the US spends more public sector money on cancer research than the UK, which feels crazy, right? And then if you take the total spend on cancer research and you take the private sector money out of it, research charities like Cancer Research UK fund more than half of what remains. So my question is, is the compact between the public, private, and third sector in the UK when it comes to cancer research, when it comes to life sciences research spend, is that compact broken, and do we need something that replaces it?
Okay, who would like to tackle that? Hesitation.
I can quickly, furiously agree. And it's interesting. I used to work in cancer and have now moved into respiratory. And one of the opportunities that we very much saw as a medical research charity is the life sciences missions as a way to perhaps strengthen or reinvent the compact and to signal in certain key areas we needed more energy and focus. We find ourselves in respiratory with no funded settlement, with public funding of research at around a third of what we think it should be versus burden of disease. And you see the consequences in outcomes, and you see the consequences in active research. So I think this is something that if we're really serious about making the breakthroughs, there's a very quick anecdote. So I worked at Cancer Research UK for 15 years. The most frequent question I got asked by people who knew I worked there was, oh, so-and-so, my relative's been diagnosed with cancer. Do you know if there's a clinical trial they can go on? And of course, in a way, cancer is the most fantastic success story of a very active patient research, many thousands of patients enrolled on cancer clinical trials each year. In respiratory, we are just worlds away from that.
So you're the Cinderella?
Absolutely, absolutely. And so I think particularly where, there's high unmet need, and you do have strong medical research charities, we're often still forgotten or, an afterthought to some of these conversations, to be frank. And I think strengthening or reinventing that compact would be to the benefit of all parts of the ecosystem.
So it's effectively one-sided in terms of where it's going. That's the vibe I'm getting.
Well, no, but I think
perhaps one-sided is the wrong term, but it's to the detriment of other conditions which are equally deserving of the right kind of funding.
Well, I think it's about sort of levelling up, but not to for conditions to be played off against one another.
Sure.
I think there's a huge opportunity to draw on the strength of medical research charities and their links with patients to do more and better.
Right, but levelling up really encapsulates it all, really, doesn't it? So can I get the response?
I think it's more about acknowledging the role that these groups play in research, and I don't think it's known or understood how much significant investment in research is done by these charitable organisations. I don't think there's public awareness, and I'm not convinced there's necessarily awareness across the board within policy makers or decision makers of their role, particularly in the early research space where there is partnership, as JBT said, in terms of academia, life science and the charitable sector. Yeah. I think in terms of balance, I think what is actually a concern is the areas of research that have been most negatively impacted is unfortunately oncology. And, when you look at those trials, if you can't recruit onto trials, if they don't have the diagnostics available, if you don't have the pathways available. So I think, in fact, rare disease and oncology are the two areas that have been most significantly impacted in the decline. Respiratory is working from a lower base, I suppose, but I think it's a very good point. There needs to be more awareness on these areas, and I think people who know about it would be willing to get involved.
Absolutely. Can I just jump in, because we've got 5 minutes left, 4 in fact, and I do want to squeeze in some more questions which have appeared on the tablet, but would anybody else like to address that question from Cancer Research before we go to the tablet?
I'm just going to say something super brief, which is I think it's important to recognise that charitable funding funds more than research. It also funds health infrastructure, so people and buildings and where people go for care and support for patients, and it's important that that is recognised. It's an enormous part of our healthcare system and incredibly valuable and life-saving. But I think there's something more fundamental that we need to understand. It's about how all the different parts of our funding infrastructure work together and how well they work together. So I think the velocity of money that goes through the different bits of the system, the NHS, the UKRI, and NIHR, the charitable sector, and how well that's working and how effectively it's working. Because I think sometimes it's not delivering on the priorities which they've been set out to do, and therefore you have some projects which are funded and they miss the cycle because of various different reasons, and that is fundamentally a waste, and people who could have been saved don't get saved.
Okay then, let's take a question here from the tablet, and it's basically a technical one, or technology. AI and tech, what do you think of current adoption levels in the UK versus the rest of the world? And what do you think the opportunity is to address some of the challenges we are discussing? Again, using AI and technology, so who would like to tackle that?
Yeah, I will. So I think we're on the beginning of a journey. I think certainly at the university we've got through that kind of first phase of every student's going to cheat, and then robots are going to attack us and kill us all. And we've got into a kind of more mature conversation about that, actually AI could probably really speed up the discovery of new medicines. AI could probably do a lot better than humans in terms of taking patient-facing materials and doing more in the health literacy space so they're actually understood and are contextually relevant to small groups. So AI it'll just get better and better as it learns to do that. We are at the beginning of a journey that's been announced about very seismic increases in healthcare worker training between now and, shall we say, mid-30s, as it were. We're going to struggle for clinical placements and how to make that work. One patient, one doctor, one medical student, one clinic isn't going to work in the future. We'll have to start thinking about virtual reality teaching solutions, and that's going to involve AI.
Okay, so again, very briefly, the response to that question about AI and technology, once we've actually stripped away the fears.
Yeah, I mean, I think actually there was some media on it on our organisation earlier, and absolutely right. They're right across the chain. So Paul Hudson, our CEO, is passionate about the role of AI in our future. And in the early discovery phase, how can you actually find ways that reduce the time, reduce the resource, reduce the burden on all of the various approaches to actually define new molecules that can make a difference using AI. So that's that end. And then right at the other end, in terms of supporting the distribution, supply mechanisms and the quality, there's a whole piece of work in terms of how AI can also amplify humans and also make, ensuring something's got the right quality, much faster research. And so right across the value chain of certainly the life science sector, AI is going to play a role, and it's not just searching on ChatGPT for your next essay. So, yeah, we're huge committed fans, and I think the other point you made about trials, enabling trials to go straight to people and patients who want to get involved without needing to visit and drive long distances to get to see a clinician, that's definitely got to be the future.
Okay, then would anyone else like to respond to that very, very briefly? And I will try to squeeze in another question. And what I would ask is that your answers are very brief, but please, in terms of AI.
Well, we've spoken just a lot about the pressures on the NHS and, administrative burden. And, rather than AI, administrative and ML solutions for back office. So risk stratification of patients
Machine
on
learning.
waiting lists, for example, making sure that payroll can be delivered more effectively, making sure that you can do much more effective rotas that are better and kinder to staff, things like that. And there's lots of those solutions which are already available and in the market. And if those could be delivered within the health system, we might actually have a more effective and happier NHS.
Okay.
Would furiously agree with that. And Lord Darzi and IPPR did a report in 2018 suggesting AI and robotics could save the NHS 12.5 billion. It'll have only gone up. And the only other point I would make is that it's a real source of strength in the UK. We have some really cool companies doing stuff with AI. So like Chiron Medical, their technology platform for mammography screening for breast cancer. Okay. Amazing. We should be really proud of it.
Don't run away from it, embrace it. Okay, and I have to stress, I do want a brief response to this. This is a combination of an observation and a question. Innovation is not necessarily the answer to an increasing health need, but the reality is some patients in the UK do not have access to medicines which they would otherwise have access to in other countries due to differences in reimbursement. How can we improve patient access to medicines that are not deemed cost-effective by NICE? Very briefly. Rather than starting with you, I'm going to go to Jessamy. So you've got a bit more time to think
Very
about a second response.
Very briefly, NICE was set up to stop postcode prescribing, to get consistency and adoption of valuable innovation to the country. And there is a question about making sure every pound that is invested is value. I think there is a difference between what's available here and elsewhere, but actually there is also a difference of use in medicines that are cheap as chips. And it's not necessarily about the entry system, where we do have some challenges, particularly in rare diseases and oncology. There is actually an issue of not using stuff that's available right across the board. So it's back to the adoption point.
Okay, Sarah.
Well, I was in Cambridge yesterday, a very uplifting morning, and partly looking at the pathway for severe asthma and biologics. Adoption is coming, it is slow, versus other parts of the world. So I think that sort of stresses, it's back to partly NHS sustainability. A comment about what patients want. Of course, they want treatment that is right for them, and they want to feel they're getting access to the best, and they want to feel there's equity. And I think too often, and actually this is something we're going to have to watch with ICBs and commissioning shifts, the postcode lottery is something that is sort of expressed to us from a patient perspective. I think we all have a job to do to describe what's best, to encourage that patient empowerment to go and seek it out as well.
Okay, thank you so much for that. Nicola.
Well, I think one of the first things we should do is do everything we can to innovate in clinical trials and clinical research so we can make it more affordable and the product that you get out the end of it is more affordable. That's the first thing. But then the second thing is around adoption. I do think we should look at supply chain processes and think about legacy products because obviously you want to allow for independent professional judgment in giving the right product to the right person, but sometimes you have a question about the supply chain, and so I would encourage looking at both ends, reducing cost going in, but also not leaving products on there which are now out of date.
Great, Paul.
The only thing I'd add is the sort of patient and clinician voice in the NICE decision-making or HTA decision-making process. That came in after the last NICE methods review. We need to see more of that. We need to stop seeing the NICE decisions quite as much as sort of firm health economics. That sort of patient clinician voice and understanding of the need there is important.
Okay, final word to you, Jonathan. You are allowed to have more than one word. You can have two.
So a national conversation with the population about what we want in our healthcare system for the future, what we are prepared to pay for it, and how we are prepared to fund it.
I think that sums it up brilliantly, and I think these guys deserve a big round of applause.